Okay, I think we'll call the meeting to order. I'm filling in for Carla tonight. So hope you all had a nice Thanksgiving and a not too lonely Thanksgiving. I guess we'll take roll.
Allen Ginsberg.
Here.
Andrew Held.
Here.
Carla Pohl. Corey Tello.
Here.
Hannah Eisner.
Here.
Judy Buchanan. Richard Janetti.
Present.
Robert Kohlhase.
Here.
Scott Hume.
Here.
Sonia Reese.
Here.
Susan Schaefer.
Here.
Do you have any public participation tonight?
No.
Has everyone had a chance to look over the minutes? Anyone like to make a motion to approve the minutes? Susan makes a motion.
Can you approve the minutes?
Sonia makes a motion.
Yep.
Susan seconds.
Okay. Allen Ginsberg.
Aye.
Andrew Held.
Aye.
Corey Tello.
Aye.
Hannah Eisner.
Aye.
Richard Janetti.
Aye.
Robert Kohlhase.
Aye.
Scott Hume.
Aye.
Sonia Reese.
Aye.
Susan Schaefer.
Yes.
We have a consent agenda of bills to be paid. Would anyone like to make a motion?
I so move. Corey.
Corey Tello makes motion.
Eisner second.
Any discussion? Okay.
Allen Ginsberg.
Aye.
Andrew Held.
Aye.
Corey Tello.
Aye.
Hannah Eisner.
Aye.
Richard Janetti.
Aye.
Robert Kohlhase.
Aye.
Scott Hume.
Aye.
Sonia Reese.
Aye.
Susan Schaefer.
Yes.
Okay.
So I have a few informational items. Our first is a presentation on problem-solving courts. I believe Mike Donovan's going to talk to us about that. Good evening, Mike. Thank you for joining us.
Good evening. I do have a presentation on problem-solving courts. I was asked to speak and some questions were presented. My coordinator put together a little cheat sheet for me since he's the expert and I'm the boss. So I will go through this information and be happy to answer any questions if you have any. Can everybody hear me okay? They asked for like some 3-year information. So we have information from 2017 through current numbers. Service numbers for the recovery court, the mental health court. We've had 173 referrals, 38 clients accepted into the program in that time frame. Total number of clients served during the 3-year period was 58. Graduation data, we've had 22 clients graduate. We've had a 9% recidivism rate. And just so you know that we spent the CJCC spent the better part of a day just trying to figure out what we would consider recidivism, since there's so many definitions for recidivism out there. We do 2 years post arrest and conviction, post program, but we do not look any further than local. We do not run leads on clients, so we don't have information if they were arrested outside of our aegis area, which is the county here. For drug court, we've had 330 referrals, 87 accepted clients in that time frame. We've served 127 clients since 2017. We've graduated 45. The recidivism rate is higher. It's 36% with drug court clients. For both of these programs, we have a cool program information thing that's provided by our case management system. We use Connexus Cloud, which is a cloud-based case management system, and it figures out community savings based on a number of factors, not just not locking somebody up and manpower factors, but it uses a pretty intricate formula. And the current cost savings for the community based on this programming for recovery court during that time frame is over $450,000, and for drug court it's over $1.1 million based on their formula. And I'd be happy to provide that. I don't have that with me, the exact formula, but it's one of the selling points of this management system that we have. They do a cost benefit analysis, and it saves that. Some of the talking points that John brought up is that the biggest problem we've had is establishing an alumni group for years. You know, what happens to these people once they leave our care, if you will. We've struggled with that forever and not just us, nationally, they struggle building a alumni program that is, that can help people sustain their recovery. It's a bigger problem for drug court than recovery court. Recovery court clients tend to stay connected with their agencies than the drug court clients do. Referrals have been down, especially this year because of COVID, over 40% reduction in the referral rate. And that probably, a lot of it has to do with the court cases that had stalled for a number of months due to our shutdown. And I think that's all that John presented to me. So if you have questions, I'd be happy to attempt to answer any questions you may have.
Corey?
I think I missed, how many did you say in recovery court were accepted? You said 173 were referred, and then how many accepted?
38.
38, but then 58 were served. So I'm a little confused by that.
That's some people, number of clients served could be the people that were in the program prior to the start of the year when he started collecting data.
They were kind of they were like carryovers, so to speak.
Yes. Yep.
Okay. And then can you explain why, like, why so many of the referrals are not accepted? What are some of the reasons why they would not be accepted?
Yeah, and part of that is a problem that we have with capturing data, but it's what's been required by the certification process, is that anybody that they contact us on is counted as a referral. Okay. And so a lot of those people, especially in recovery court, more than any other program, they choose not to do the program. Both programs are consent. You know, the client has to choose, and with that audience, they choose not to take it on. That's one of the biggest issues with that. Plus, there's a number of those people in that 173 and in the 330 for drug court that are not either statutorily eligible or for whatever reason they do not fit eligibility requirements. Now, those requirements have become a lot less stringent as statute has changed over the years. So the number of clients that we turn away now, or that are turned away from the program, is considerably less. If we broke this down year to year, I'm sure the percentages would be much less now than they were then. They used to do what they call a voting process during staffing. And so then somebody could vote no, and then whatever the majority was, somebody could be voted out. That is not allowed any longer due to certification. There's no voting. In a staffing that they will talk, they will get a chance to speak about the clients, the different team members, and then the judge makes the decision. And the judge still has the ability to say no, but he's the only one in the room that can say no.
Thank you. And I've got one more question, and that is, and this is a biggie. So
Okay.
you just did a great job of identifying the savings from each of them, which is sizable. So is there a reason those savings do not go into funding the program so that our dollars could be used in other ways? So the $553 could be used in other ways if you're realizing that much of a savings.
That's a great question, and I think that's probably above my pay grade. I've asked that question too. I mean, I don't know. You know, when they had this formula on the dollars saved, you know, we're saving money from jail or like adult redeploy. We'd have a cost savings to Department of Corrections, but Department of Corrections doesn't give us that money, you know, to run our adult redeploy program. Somebody with, you know, up above handles that. That's a great question. I truly don't have an exact answer for it, but it is something to look at. If we are saving that much money, where's that money going?
Yeah, and I appreciate your honesty about that and your transparency. So, and I think it would be great to have more information on that.
I think it would be something we'll look at. I'll put a note down because I agree with you. I mean, I'm not going to try to sugarcoat it. There should be ways that should be given back somehow.
Judy? Can't hear Judy, right? Mic's not on.
Yeah, Michael, I'm sorry. You mentioned the 9% recidivism rate. Was that just for recovery court or for all of the courts?
Recovery court was 9%. Drug court's actually 36%.
Okay. Now, you mentioned you served 38 clients, or 38 clients were in the program, 22 graduated. Do those people who are in the program who did not graduate, are they considered into the recidivism rate as well?
Only if they were arrested and convicted during that time frame. We don't count unsuccessful discharges or other terminations as recidivism. No, ma'am.
And okay, so what has become of those people who were, who dropped out, who maybe were not convicted or of a crime during that time?
A lot of people choose not to graduate. They either time out of the program. They complete their term of probation, their time limit that they were on probation, but they did not meet graduation requirements, and so they're given a neutral discharge, and they're allowed to terminate probation as what we call scheduled termination. That's the majority of those. There's unfortunately with both these programs, we do have early termination due to death in both of these programs. We have some numbers regarding that. And we have others that may have got revoked and chose to take a jail sentence as opposed to completing the program.
And is the 9% rate, are we able to compare that with other similar programs? Is that in a range of, is that good, bad?
9% is pretty good for recovery court. Recovery courts are hard to group together because they're a little different than drug courts. Some recovery court programs like ours will take misdemeanor offenses and felons. And when you start mixing that audience, the recidivism rate looks a little different depending on the risk of the clients. And then some are diversion programs and ours is not. So it's hard to compare. If we were to compare against a very similar program, I think our rates 9 and 10% is probably about a national average
Okay.
for those types of programs.
And I just have one more question. When you referred to 173 referrals into recovery court, but actually only 38 entered it, are there some, and I think I'm picking up a bit on Corey's question, of the referrals, is there some time, substantial time and cost incurred in reviewing those 173 before you get to the 38 that you actually serve? Are there some costs in there, or is that a kind of a quick process?
It's not as quick as we'd like it to be, but it is a fairly quick process. That's one of the things we've struggled with, but as part of certification now through the state, they put us on the clock. So we have to respond and go through the process by certain benchmarks, and they put us on the clock, if you will. And so it has gotten much quicker than it has. A lot of, like I said, if we had a breakdown, and I would be happy to try to provide that to you, if we had a breakdown of each year separate instead of pooled together 2017 through now, we would probably see some marked differences now that we have a statewide certification process for these programs when we didn't before.
And is that certification process, has that added to the cost, and is there an annual cost to continue to be certified?
No, there is no cost. It's through Administrative Office of Illinois Courts. It's a pretty stringent process, but there's no cost involved. It is time consuming. When I took over as director a year ago, we were just submitting our recovery court certification packet, and I had to redo it. And so it's extensive, but there's no cost to the taxpayer for that process.
And lastly, then, could you provide us the annual, rather than the cumulative year by year picture of the numbers that you just shared?
I don't have it with me, but I can get that for you.
Yeah, if you could just
Yep.
get it back to our staff. Yes.
Yeah,
Thank you.
John is super good with stats, and I'm sure he can break that down for me. And if there's something that we didn't include on here, just let me know. We have a pretty extensive report that we do quarterly with Amy, and when we meet. So a lot of that information is out there and available for review.
Okay, thank you.
You're welcome.
Sonia, you had your hand up.
Yeah, I was just going to say, back to the savings. When I hear somebody say that, I generally assume that's a calculated or an assumed savings had this person gone on and had the problems. Not that you actually had that money in your budget and you didn't spend it. Not a real savings. It was a potential savings. Now, I don't know if that's how you're calculated, but that's how I hear when somebody says that.
Yeah, if it's
really money you budgeted and you suddenly didn't spend it, then that's different. But
yeah, you're correct. I guess you would call it's a projected savings that like I said, we have a formula from Ken Taylor that did this program for us, and they've done it for a number of places, but we're one of the only ones in Illinois using it. And I could look at for you guys what the formula considers, but it takes into account cost of incarceration and other dynamic offenders, factors like childcare, employment. It's a pretty complex formula. So yeah, it is. It's very hard to make it tangible dollars.
yeah, it's a what if. If they didn't do this, we might have spent that, but it's not like you suddenly. Okay, thank you.
You're welcome.
Anna?
Thanks, Mike. A couple questions and follow up too on the savings. I know that the county is a FUSE program now, which is sort of a premised on the idea of savings to the community and not having as many visits to the emergency department or hospitalizations. And I don't know if that sorts of information is coming into what you've described as savings. So I'd be curious again to get a better idea of what that means, whether it means other organizations are less burdened because of the help being given.
Yeah, I was in on the sales pitch when they brought this program to us a number of years ago, and this was a big part of it. But so I can't exactly remember the formula, but I'd be more than happy to get it for you, and so it'll break this down for you.
Yeah, and I think that brings to mind the question of just what other connections do the folks who are in the program have with other service providers? At the time, I assume they're going through it. And let me back up a minute. I know I've heard of drug court and recovery court. Can you give us a Reader's Digest of, the health department funds 3 agencies to support the program. Can you kind of just go through, because I'm assuming some people really aren't that familiar with what each does. And with that, I'd kind of be interested in knowing how things have gone with COVID and, how the costs look with that or not. And she said referrals are down. So when we fund at the same level from the health department money every year, without looking at population. So
Sure.
That's kind of a lot of questions thrown into one. I'm sorry.
Yeah, no, I understand. Yeah, so I can give you the Cliff Notes version that out of the money that is sent through us to the 3 agencies, which is Chestnut Health Services, Center for Youth and Family Solutions, and the Center for Human Services, the majority of it goes to Chestnut to provide substance abuse and now some mental health treatment to clients in both programs. Most clients in recovery court get the majority of their services from the Center for Human Services. They provide counseling, caseworkers, a lot of different services for their money. And then the Center for Youth and Family Solutions, I think under this program, does the MRT, the moral recognition therapy is their contract. I just got done submitting a number of contracts for all different programs. So if I get them mixed up, I apologize because it's kind of scrambled. We contract with these agencies on a number of fronts. But that is, like I said, that's the breakdown. We do provide like I said, the report that we go through with Amy Hancock, the quarterly report, really breaks down the services. And I don't know if you guys get a chance to see that, but it breaks down specific services almost to the hour of where the money's going. And it's very informational. What was the rest of the question? I'm sorry, I lost my train of thought.
That's okay. And you're right. I mean, we get that in other forms. COVID, I guess, referrals were down. Where do you see things going? How has the delivery of services changed?
It has, because I know a lot of it has gone to virtual. I can't remember. This week I got an update on Chestnut, and I think they had talked about going back to a fully virtual type of treatment modality again, because they moved back to having groups, but with everything with COVID, it's kind of puts everything on the back burner. I do know that when I initial the bills and the submissions, they have been less. So because of, if they're not doing as much services, then they're not billing as much because they bill per service. And so, so I don't know. I haven't looked recently to see how much is left after this year, but with COVID, I think the big issue is that, we're going to feel it more next year than this year, because all these people were in the program before COVID started, but now our referrals are down 40%. So there's going to be a lot less bodies in the program, and there's going to be less bodies coming in over the next few months. So as people exit the program, then our total numbers are going to stay low. And so it's going to be less for service. So I could see there be a surplus by the end of the year, by the end of next year, for sure.
Bob, I think you had a question. Rob?
Yeah, I would like to suggest that I think we should come back to this topic again after we presented some information that we can read beforehand, because this is a very interesting topic, and I think I can sense that everybody will have a lot of questions. And so I'd like to get a little more information and come back to this, because we could spend, I think, the whole night on this topic, and I don't know if it's fair to Michael to keep giving these questions. So for sense of time, I'm suggesting we move on, but I have another session on this where we have an executive summary of what you have, Michael. And I would suggest, based on my experience, that the cost savings, and I don't know this for a fact, it sounds more like it's a cost avoidance as opposed to savings, that you're avoiding costs, and then the word savings comes in, and
Sure.
so then that leads to a whole nother conversation about who's saving money.
Exactly. And I'm very happy if you want to send me a list of specific information you want. I can get with my team and get you something so you can have it ahead of time. And I'd be more than happy to come back and maybe bring my coordinator, because he knows this stuff. Like I said, I have a working knowledge, but John's the expert. John knows this stuff inside and out. And so I'd be happy to come back with him, and answer all your questions.
Susan?
Thank you. I would like to suggest, unfortunately, right now with COVID and graduations and stuff like that, they're not in person. And I don't know if you've actually had any, if they've been virtual, because we used to get the information as to when graduations were. And now that they're probably virtual, we don't get them. But once we actually go back into having in-person graduations, I would like to suggest to everyone to attend graduations for both recovery court and drug court, because they are pretty informative. You can see that the clients, you can see the ones that are still in the program supporting the ones that are graduating, the ones that have graduated have come back and supporting those people that are, still in the program or graduating. And also, if you have the opportunity, and I don't know how you're doing this now, Mike, and this is, I guess, one of my questions. If you can attend court, either actually when they go to court once a week, I think it is, or
Correct.
Is that right? And it's like on Thursday afternoons. Am I right on that one?
Yep. Drug recovery court is at 1 and drug court's at 3:30.
And just sit through the participants, going in front of the judge and hearing what has happened in the last week, and if they've been sanctioned, or if done something good, and that kind of thing, and how the clients are actually responding and actually moving forward and making improvements in their lives. So it was very informative, and usually right before graduation they actually have court too. So so I don't know, how are you doing those weekly courts now? Are they virtual or are they in person?
They are virtual unless somebody's going to be sanctioned. So basically compliant clients are not coming in person, but if somebody's going to get a sanction from the court, as far as I understand, then they're coming in front of the judge for that type of activity. The graduations have been basic. They've been virtual. They've been at the bench. None of the pomp and circumstance, very low key. We wanted to continue that. We have 2 Veterans Court graduations, I think, next week, if I'm correct. And I think they're just going to be in front of the judge at the bench, and then they stream it to the other circuits, the other counties in the circuit.
Okay, thank you. But like I said, I would suggest, if anybody has the opportunity, when we actually do go back in session and things like that, to attend the court sessions, 1 or 2, and then attend the graduations. They're really good.
Yeah. It's a pretty interesting event.
Any other questions or discussion? Hannah?
And Bob, I think that's a good idea. If we want to drill down on things, it probably bears another meeting. I'd offer, I guess, that, we have the Behavioral Health Funding and Policy Committee. So if rather than have the whole board meeting, I mean, we could certainly invite Mike to come to that committee meeting as well. Just real briefly, Mike, how many people are in at one given time typically?
Our drug court's capacity is 50. I think last time I looked, there's 33 or 34 in drug court, and recovery court has, I do the stats every month, has I think 15 right now, but their capacity is 30.
Okay, so that's the COVID problem we're seeing.
Yeah. As people leave the program, nobody's coming in.
Okay. And how long do they usually spend in it? Varies by
Recovery court's anywhere from usually 18 months to, I guess 36 for some felons, and then drug court is usually a 36-month sentence. And then most people that graduate get an early discharge and leave early.
Okay, great. Thanks.
Yeah.
Amy?
Thank you. Mike, I just wanted to also quickly touch on when we were talking about the cost and the referrals and how it's decided on who enters the program, that it would be the individuals that would be considered high-risk offenders. And so the individuals that are being placed into problem-solving courts have experienced a lot of things in their background, trying to say it appropriately, but they've worked up to being part of this program. And since
that's what it. No, you're good. That's what excludes a lot of the referrals. That's a good point, is that a lot of people get referred, but they don't score high enough on our risk assessment tool. And we have guidelines from the state that they have to be high risk, high need. And so if they don't score high enough on our risk assessment tool, we do not accept the referral, and then they usually end up down in regular probation, or with one of our other programs.
And it's very clinically, because of the intensity of the services and the regulations and monitoring and the things that these folks have to do, it's clinically appropriate for it to be high risk offenders because of the intensity and that higher level of care, so to speak. It would not be appropriate for low risk offenders to do it. It would be overkill for those individuals. And then just real quick too, Mike did touch on like the contracting with the 3 agencies, and there's a multitude of programming provided through that program. And so these individuals they're doing a lot of work when they're in this program. So it's very intense. Through those 3 agencies, it could be coaching by peer specialists. And I know that that's been kind of a hot topic with the board recently. There's the weekly staffing with the mental health, the substance use disorder during the team meetings. There's the MRT therapy provided by CYFS. And the purpose of that is specific to individuals that are involved in the justice system, and is to help them challenge and change their thinking. The thought is if they can change some of that thinking and learn how to react differently, then maybe that would help divert them or keep them from entering the justice system. And also when we were talking about like whether it's cost avoidance or cost savings. So these folks are like, if it wasn't for problem solving courts, they would probably, for some of them, Mike, and you can correct me if I'm wrong, their choice could be you either do problem solving courts or you go to IDOC. So like this could be like last resort before they would go to IDOC. Now, obviously it's a very, very expensive, and it's not last resort to take someone out of the community, and the consequences that goes along with someone being housed in the Department of Corrections. So I just want to add that.
A number of our drug court clients have lengthy DOC histories. And whether it was before they ever had a chance to get into a treatment program. But yeah, DOC is definitely the option if they can't get in these programs, for sure.
Corey?
I know we're supposed to be wrapping this up, so thank you very much for that clarification, Amy, and I appreciate the information, Michael, and I do look forward to, us generating some very clear questions and getting to loop back around on this. I do have a question though about the peer specialists. Are these certified peer specialists so that their hours are billable, or are yes or no on that?
I can help out, Mike.
Yeah, because I'm not 100% sure. I know Chestnut there's a process, but I don't know what it is.
So I don't know if any of the peer support specialists are certified or not, but Chestnut has clearly stated that the peer support specialists, all of the activities that they do with them, which are a lot of like case management or just literally activities to show them how to be able to live, like just do normal day-to-day things. But according to Chestnut, they are non-billable services. So according to Chestnut, if this funding didn't exist, because most of the funding that goes to Chestnut is the peer support specialists. And so according to Chestnut, if this program didn't exist, if the funding didn't exist for the program, then the peer support specialist would be cut out.
So maybe with the Heartland program now where people can get certified, maybe that's something that, again, big picture down the road, maybe that's something to be looked at too. Thank you.
And I think it then also goes into, like even if there's a therapist that is certified, there's still billable versus non-billable services. So, and I don't know as far as like with peer support specialists, if someone is certified, then what does that look like for billable versus non-billable services? So we would definitely have to look into that. And then real quickly, just the last thing, I can be your contact person. So if you guys have questions that you would like Mike to answer or John to answer in the January report, you can send it to me and I can generate them and send that to Mike. And then the same thing with Mike, if you have things to add to the board, then I can, it's probably easier just to send it to me and then I can easily distribute it.
Okay, whatever. Yeah, I can do whatever.
Okay, thank you for joining us, Michael. We appreciate all the information you've given us tonight.
Thank you. Have a great evening. Bye-bye.
Next on our informational items, we have the Behavioral Health Services Agreement, the template contract in the package. Is there any questions or comments on the agreement? We don't even do anything with this.
Just information.
It's information. Next, we've also got the National Council for Behavioral Health application for informational purposes. Is some staff applying for this?
Yes.
Is this the first year this has been done?
I can speak on that if that would be helpful just real quickly. We just wanted to reach out to you guys and let you know, like there's a couple different things that we're doing, especially now that we have a behavioral health specialist. That is absolutely amazing. So we're applying to the Illinois Association of Behavioral Health. It's a very cheap membership. And so we're applying to that. And then that would give us membership to the National Council for Behavioral Health. That is definitely one of the lead federal agencies in providing up-to-date information on behavioral health services, including trauma-informed care. So we're super excited about that. But my behavioral health specialist, Taylor Davis, ran across this application for the grant that was provided in the packet from the National Council. And what it really is just providing a lot of tech support and training in different areas that would be beneficial. And the grant is specific to public health. And we have identified someone, Heartland Head Start, to be our agency to connect with to move forward on this. And so it would just really help us just kind of continue to be a lead in behavioral health, but kind of like the insides of it was provided in your packet. If you guys have any like specific questions, the application is due December 18th. And so we are actually meeting tomorrow to wrap up the application and have Jessica review it before we send it. So we're in the process of getting ready to send out the application and hoping we will be selected.
It's Corey?
Just so I'm clear, so this will provide training to Heartland Head Start staff, basically. I mean, some webinar related training related to technical support. Am I reading this correctly?
It would provide that to us also.
Okay,
It's a partnership. So it would provide it to the health department. And so the reason also, so we definitely took the initiative to apply for this because these are things that we want to incorporate and to be able to have a focus on within the health department. Our home is always very important to us as far as like doing this work. However, the application did state that there was preference given to those that had a community partner. And so we've done work with Heartland Head Start with one as far as like on some trauma-informed care work and just behavioral health in general. And so hopefully it should be beneficial to both agencies.
And the grant is for how long?
I think it's 6 to 9 months.
Okay.
It was like a series of, there is very scripted as far as prescriptive, as far as like what you would receive. And it has you check, like, can you do these trainings? Can you do this? And it already has the date and times of those. And so our behavioral health specialist is able to commit to that. And so, but I think it's a 6 to 9 month period. I know it's no longer than a year.
Thank you, Amy. Anna, do you have a question?
Yeah, just so I understood, it looks like it's targeting a person in our organization to receive the trainings. Is that correct?
So I would be the contact person, and then Taylor Davis, and she's kind of more of that front line, so to speak, person in the behavioral health program. She would be the one that would attend the trainings. And then just to kind of follow up on that, Hannah, Taylor is doing other trainings on trauma-informed care principles and behavioral health topics to the health department. And she's also doing a training on trauma-informed care during the Behavioral Health Coordinating Council Forum in February. And so Taylor has really definitely embraced that role as she receives a lot of information from trainings and research. And then we work together and to find a way to distribute that. And so the things that she learns, we'll work on, like, how do we pass that, kind of filter through that information and make sure that is being distributed appropriately.
Susan?
So kind of another follow-up kind of on this. So this would help us to become a trauma-informed health department. And that's the goal of getting this training. And then by partnering with Heartland Head Start, that would help them achieve the goal of being a trauma-informed agency. Is that what the whole purpose of this is?
It's not the entire purpose of it, but it is definitely part of the purpose, is that this will be one of the other things that we will be doing towards becoming a trauma-informed care agency. And you're correct that the reason why we asked Heartland Head Start to go in with this, to collaborate with us, is because they are also working very diligently on becoming a trauma-informed care agency. But kind of like the whole picture of it is behavioral health initiatives that, and I think there's even some stuff specific to like mental health and COVID-19. So the whole purpose is more behavioral health initiatives, but there's definitely a highlighted focus on trauma-informed care.
Any other questions? Thank you, Amy. Sounds like a really good opportunity. Next, we have committee reports. Behavioral Health Coordinating Council, and Sonia.
And We're meeting on Friday, and I'm still kind of looking for the agenda. I think it was to come out sometime before the end of the day today. So I haven't seen it yet.
Okay, thank you, Sonia.
Yep, you'll hear more next time.
Behavioral or Mental Health Advisory Board, Corey?
The advisory board is not met, but the marketing committee has, and I'm just going to hit some really quick highlights on the marketing. If you remember, that committee was formed to try to see if we could increase the capacity of our community county to know that 211 exists and know that they can and should seek the services through 211 if they're having any kind of anxiety, depression, et cetera, and all the way up through crisis. In doing our due diligence, we have learned that PATH, who obviously operates the 211 line, that they are doing a fabulous job. They are definitely getting increased call volume. It's going up each month. The call volume, clearly people are responding like we all are to all of the issues related to COVID and social injustice, et cetera. So we are a bit concerned that if we market too aggressively, we may market them into not being able to hold to all of their criteria about, can't have too many abandoned calls, have to answer within a certain number of seconds, et cetera. So we are definitely working hand in glove with PATH and United Way to know how to do this marketing, again, very judiciously so we don't outpace the capacity of 211. So that's number one. But what has happened in our efforts to start, building relationships to help us market to neighborhoods, communities, populations that we have not, that have underutilized 211 or that have good reasons not to trust healthcare system in general, including behavioral health. We have made some wonderful outreach to, for example, we had a wonderful conversation the other day with the health committee of the NAACP, the local NAACP, and got amazing ideas for how we could work together. So not just focusing on just using 211, but just how we could start building alliances that would help us even get, as we go into the vaccine period of time and know that we may have some vaccine hesitancy on the part of people of color for, again, very good reasons because of historical things that have happened. We could partner on that. And what Amy pointed out, and that was a very good point, was that we certainly want to work again in tandem with the health department's emergency preparedness department and health promotion department, so that any inroads that we are making, we are putting everybody in touch with everybody else. Because if we can work with the health committee of NAACP, I learned from the DuPage Mental Health Center in Wheaton that they have a health equity and access team building team that they put together, and they're working with township supervisors to get out into, and so I'm thinking that could be a way for us to connect with rural areas. So this heart team at DuPage, I think we could use some great ideas from. And then Judy's looked into, some ways to do marketing through signage, et cetera. So anyway, we know we've made some great inroads that I think can be used big picture in a variety of ways that we definitely want to build on, but we want to also make sure that we're working very closely with the health departments that are tasked with doing that work. So I hope that made sense. And if you have any questions, let me know. And Judy, did you want to say some things?
I was just going to add the obvious. I think this all originated with a desire of the advisory board to make sure people knew of the help that's available in our community, raise awareness, reduce the stigma. There is help. And really on a bigger scale, what we've kind of transitioned into is doing that very thing, but in a little bit different way. So it's been very, very good to take the time that's been taken by the committee to really reach out to a lot of people, because I think we have a better understanding now of how to even be more successful.
And we know we want to get that, there's the 211 coping campaign that's been on billboards and buses and things, and it has a certain graphic. And we realize that, again, we want a graphic that we make sure appeals to and resonates with all of our residents. And we want to put that graphic in front of some focus groups representing different populations, so we make sure that the message is a good fit for different groups. So we're also looking forward to that. I should also mention that reached out to the McLean County Interfaith Alliance also. So, I mean, there's some great connections that I think we should be putting, the health department should be, again, really looking forward to building closer partnerships with.
Thank you, Corey and Judy. We appreciate all the work you put into this. County Board, Susan?
Thank you. The county board, the new county board was sworn in on Monday, and we had our organization meeting, and new committees were, assignments were handed out. I'm still chair of health committee, so you guys are still stuck with me. But we do have some new members that will be on health committee for our next meeting. And so there might be some different questions or whatnot, but I think it'll be a good committee. Also, the committee, some committee dates are changing, and the full county board meeting dates are changing. Beginning January 1st, the health committee will still meet on the first Monday of the month, and so will some of the other committees in that first week. In the past, executive committee has been on the second Tuesday of the month. It is going to be moving to the second Monday of the month. And then the full board meeting will be on the second Thursday of the month instead of the third Tuesday. So that all committee meetings and the full county board meetings will be done in a 2-week period of time instead of over a 3-week period of time, to condense that and give more time for people to have other things to do if they want to do other things and things like that, and not be as drawn out. So in case you follow all of those other committee meetings, like you all do, right? That is what's going to be changing beginning in January. But like I said, health committee is still the first Monday of the month. So that was a change that was made on Monday. But our full board meeting is still, for this month, is still next Tuesday. So that means also that Board of Health meetings will be the day before the full board meeting. So if there's something comes up that you want me to relay to the full board, I can do that then right away the next day. Sonia, did you have a question about that?
I was going to say, well, I'm a junkie for places like this, meetings like this. So I tune in. So all of you can do that. If you're just itching to see what goes on in health committee, you can sign on and watch it. But I did think that the committees on Monday will set the tone for when the county board meets, that it's going to be on the Thursday following, not necessarily the second Thursday, but the Thursday that follows. Is that right?
Almost. There's, I think, 1 or 2 that is the way the months fall,
Yeah.
where it would probably not be on the second one, but the health committee meeting will get moved. There's several dates because we have holidays on Mondays, and so the health committee meeting gets moved so that it falls in, so it doesn't conflict with executive. And that's sometimes what it would conflict with executive being the next day kind of thing. So at the meeting in January, we'll have the dates for the health committee for the year, so that you'll know. And we will have dates probably at this month for all the full board meetings for the next year. Actually, we did that. We did that at the reorg meeting. So yeah, so that's like I said, if you tune in and if you miss one, you can always go to the YouTube channel and watch it later, instead of watching it at the same time as happening. So We do have
can
that
watch it.
option.
You can watch it multiple times.
Yeah, I mean, if you just like looking at all of us, you know, kind of thing. So, and speaking of that, on BHCC, I guess we had the forum had our first presentation, and there is another one next Wednesday, I believe, the 17th, I believe. And it's ending the silence for families. So it could be a timely topic, and it's going to be at 8 o'clock in the morning. But then there's also a separate YouTube channel now for behavioral health. And that's where those are going to be located so that you can watch them later if you don't happen to catch them at the live time. So, and that information is on a website, and I think Tricia sent it out to some people, and I don't know how far that's been circulated, but I can make sure that we get that out to everyone here if you need it. So that way you can know where the links are to sign up, because it'll be like GoToMeeting, like a GoToWebinar. You can be watching it live. So the first one was really good. And like I said, Ending the Silence for Families is next week. And there's a whole list of them on the county website.
We should give a great big shout out to Tricia Malott for getting that whole series put together and really making that was a concept that a group kind of came up with, and boy, she took it and ran and got the right presenters and got a schedule and got all the technology up and going. And so kudos to Tricia for her work on that.
Well organized.
Absolutely. The Behavioral Health Policy and Funding Committee, Hannah?
Yeah, thanks, Scott. We have an action item, so I think rather than doing a report now, because our committee met basically to generate that item, I'll wait and present that when the action item comes up.
Okay, thank you. Our Health Department Administrator's Report, Jessica?
Good evening, everyone. So in my report tonight are some annual program highlights, and just want us, point to those to highlight again the amazing work of our McLean County Health Department staff this year. It's definitely been a difficult year for all of us. Also in my report, I included the full COVID-19 communication plan. So last month you received the fall and winter schedule. So I wanted to go ahead and give you the full plan. But are there any questions?
Impressive.
Well done.
You have a question, Judy?
No.
Hannah?
Yeah, great report, Jessica, and kudos to all the staff and their hard work through this process. Less a question on your report, and I know we've talked about this and you may not be able to provide much information yet, but as the vaccine seems to be becoming more reality, can you help us understand really how the distribution will take place here? I hear things on the news and it sounds as if Walgreens and CVS and Kroger will be getting doses, and so maybe, we'll handle it like our flu clinics. Can you do a little explanation?
I can give a little bit. So yeah, there's still a lot that's unfolding and changing, and information that we get daily that's changing. But for the initial doses that I think you guys have heard about, that maybe, coming in the next week or two, those are intended for the 50 counties with the highest death rate per capita, which McLean County is not one of, but still, we are anticipating then shipments that come in weekly. And so right now with the vaccine, which is the Pfizer vaccine, the one that has to be ultra cold, the Illinois Department of Public Health is going to ship that to regional locations, and the health department will go get it, bring it back. And again, it's the first shipments are intended for our hospitals, our healthcare, frontline healthcare workers, and potentially EMS. So there may not be large clinics until early next year, where we would actually be looking to have those big open clinics where we're giving vaccine to the public. So that's really about all I know at this point, other than we're expecting once it starts that we will get shipments on the regular, possibly weekly. But I don't know the exact number that we'll receive. Even the priority groups are still being finalized.
And I guess my question is, it sounds like we would go get our doses along with other providers, healthcare providers. It's not going to be run through the health department in terms of a distribution on a local level. And I guess it's important for me because I think for all of us is that I think as we've gone through the initial phases with the various mitigations, and there's been a lot of comments, oh, the health department, this or that or the other. So, I think it would be important for us to be clear that we're not in that role. And I think there is some assumption maybe that the health department is kind of just part of that distribution chain. And am I hearing you correctly that we are not?
Well, for the first shipments, we are definitely part of that distribution. So IDPH will be sending it out to those regional locations. We'll be going to get it, bring it back, and distribute it to our partners. Then in the future, like you mentioned, CVS, Walgreens, they will potentially be giving out to long-term care facilities. And then again, even further in the future, yes, your healthcare providers will be giving out to the public as well. So we won't be the only ones in town that are giving the vaccine to the public. And again, there's a lot of the distribution pieces of how and who that are still being worked out. But I know the first initial shipments we will be getting and distributing.
And we have an agreement then with the hospitals to provide them the doses then? When you said partners, I wasn't sure who was included in that.
No formal agreement. We would just be giving it to them.
Susan?
Okay, I'm going to kind of follow up on that with the CVS and the Walgreens. So after we get through the initial, healthcare, EMS, first responders kind of thing that are a higher priority, and then CVS and Walgreens are kind of supposedly to do the long-term care facilities. I'm thinking about our nursing home. I mean, in particular, as health committee, and we have a nursing home, the county-run nursing home. So you would be getting the vaccine, but you would be giving it to CVS or Walgreens, and then they would be going out and giving it to the long-term care facilities, or would you actually be going in because it's our facility to do that? Or has that not ever been determined yet?
Yeah, so I think even 99% of the long-term care facilities in the state have an agreement with CVS and or Walgreens. So, the long-term care facilities we won't be going into those facilities to give the vaccine. Still not really sure on the distribution of, will it come through us to the pharmacies or will it direct ship to them? I'm not clear on that one yet.
Okay, Ginsburg?
Yeah, the problem is that nobody is clear about how the distribution is going to go. I know from what I know so far is that the first two priorities within an area will be the healthcare providers, and they don't even determine which healthcare providers. Are they only the ones working in the hospitals? Are they working in the offices? Are they working in, are they the doctors, the nurses? Are they the administrators? And then the other top priority is the nursing homes and the residents and the staff of the nursing homes. My guess would be that will probably be distributed through the health department, although the health department won't be responsible for actually giving the vaccines. My guess would be that Walgreens and CVS and the other pharmacies in town will not be getting the vaccines until they have well covered these other two priority areas. So people can't just go in and get their vaccine. Now, my understanding nationally is that Pfizer is supplying 100 million vaccines, which actually will treat only 50 million people since everybody needs 2 vaccines. But they're supplying 100 million vaccines in this first run. And lately I've been hearing that they won't be able to supply any more until next June or July. But that Moderna, the second company, is going to have the vaccine, and they should be approved about a week after the Pfizer vaccine. They've got another 100 million. So that will cover essentially 100 million people nationwide. But of those companies, they're all multinational companies, and they've gotten orders from foreign countries. And I don't know how. I mean, the president's talking about the Defense Production Act, but I just don't know how that's all going to work out. I don't think that they know nationally how that's going to work out yet. I know that they put in last spring, I guess they put in an order with AstraZeneca for their vaccine, and they put in for like 200 million or 300 million doses. But that vaccine further, they haven't even finished their phase 3 trial. So that vaccine is further away from approval. And so we're not going to see that one probably for at least another month or 2 months or 3 months. So it's kind of where we are as far as the vaccines are concerned. My other piece of news on the COVID front is that if you remember back when President Trump got coronavirus, he was talking all about the antibody cocktail. And the antibody cocktail has now been approved. There are 2 different companies making the antibodies. Both of them have been approved for emergency use by the FDA. Both OSF and Carl Broman already have plans in place. In fact, they have them in stock. They have plans in place for use of the antibody cocktail. Now, this is a different approach. Essentially, the antibody cocktail is for somebody who is first diagnosed with COVID, who is in a high-risk group. And that would be anybody over the age of 65. So that pretty much pulls in a lot of people. And then anybody over the age of 55 who has certain high-risk diagnoses like COPD or hypertension or things like that. And essentially, these are given as an outpatient. It's an outpatient infusion. And what the purpose of it, or what it's shown to do, is that it lowers the risk of developing a severe case of the disease in these high-risk people. But it's not used in hospitalized patients. Once they're sick, and the antibodies have no use. But that is already in town. I mean, that's already here. It's at both hospitals, and both hospitals are setting up or have set up distribution setups for it. You have to have a physician's order for it.
Corey?
Is there a cost? Is that a high cost? Because the vaccinations are going to be free. Is that correct? But the cocktail probably is not. But obviously, insurance would cover that. If you have the cocktail,
the cocktail itself is free. The only cost is the infusion cost. So essentially, if you would get a bill for the setting up the IV and going to outpatient an outpatient infusion place. So, but the drug itself is being given out free now. So and insurance will cover the cost of the infusion, I'm sure.
This is Dr. Giannetti. We're given it in our infusion center down in our building, our new building at St. Joe's, and I think we had 28 or 30 infusions already so far last week.
Judy, did you have a question?
A point of clarification for Jessica. At this regional center, which is going to receive, I believe it's going to be Peoria. I think I may have heard that. We will pick ours up. Are we the only entity in McLean County actually taking vaccines for distribution, or are there other entities that will also be picking up from Peoria for McLean County?
With these initial shipments, it would just be us.
Okay, and then also, in terms of vaccines, right now, we are obviously going to be a major part of the distribution process. Will the department at any time be actually administering vaccines?
The health department? Yes. So again, the first shipments are going to go to the hospitals. The hospitals are going to give to their employees. The pharmacies are going to give to long-term care facilities, but we would be giving to the other people in those priority groups. And then eventually, again, when vaccine is more widely available, giving to the public in those large clinics.
And those large clinics would be staffed by and basically provided by the health department?
Yes, and again, at that time, there also will likely and hopefully and potentially be vaccine available through, healthcare providers, the pharmacies, so other agencies having access to the vaccine when it is available for the public at large.
Thank you.
Hannah?
Thanks. So, and I'm kind of going back to those initial shipments where we are the agency responsible for picking them up and bringing them here. You're saying there is no currently any sort of agreement, or are there talks going on between us and the hospitals in terms of the number? I don't know that you know the number of doses, but so that when it hits, we all know who's getting how many and what for, so that,
So when we know, we've been talking with the hospitals to get some counts, because they even likely will have to prioritize because we don't know exactly how many we'll get. So based on how many we get, we'll determine how many they can give in their facilities, and again, in prioritizing their numbers as well.
Lori?
Yeah, I just want to I think what Hannah's point initially was a really good question, and I'm still not clear. So the health department is not going to be responsible for we're going to be responsible for picking up the initial batch from Peoria, bringing it here. But we are not going to be responsible for deciding how many go here, how many go there. That's already going to be predetermined. Is that correct? So in other words, we are not fully in charge of this. We are one of a set of partners that's going to be responsible for this. Is that fair?
We'll be determining who gets how many, but based on what we've heard from our hospitals of how many they need with their prioritization and how many we get. So that's going to be a big determinant is how many we get, because the hospitals and healthcare providers, those are our top priority. So it's going to go there first.
So you have a team, you have a collaborative team that's meeting together to analyze that data so that formula is going to be all set to go as soon as you get the go ahead.
Mm-hmm.
But
yes.
It's a team, not just us, right? Okay, super. Okay.
Susan?
I have a question for Dr. Ginsburg, but I also have a question for Jessica. I'll start with Jessica. Since everything has to have 2 doses, and if we end up doing a mass vaccination kind of clinic for a period of time, like, a couple of months or something, through the health department, not, it's like back years ago when everybody got H1N1, or there was some other vaccine that they had lines of people to get vaccinated. So I'm guessing that would go on for a period of time. What kind of impact would that have since it's a 2-dose regimen, and on keeping track and contacting and reminding those people to get their second dose? And what kind of impact would that have on our record keeping systems and staffing and things like that? I get that's my question for Jessica.
Yeah, so I don't know exact impact other than it's something we've been thinking about since the beginning, when we knew there would be, 2 doses and, 4 or 5 multiple different vaccines that are potentially going to be available. So we've been working through, what can we do to ensure that if people, when they leave, they know what type of vaccine they got. Illinois Department of Public Health is working on that as well, working on some different technology that might be available to local health departments to help us get the information out about what vaccine you received and that reminder to you of even where a clinic is that has that vaccine. So I don't have any exact answers of how we're going to tackle this other than we're looking at it and using H1N1 as a guide of what we did then, but now we've got even more different types of vaccines potentially available.
And then my question for Dr. Ginsburg is, when you were talking about the cocktails, and you said that it's obviously not a vaccine, but it helps people not get it. Can you explain that a little bit better so that people understand? And then what are the advantages and disadvantages of doing that versus waiting for a vaccine?
Well, the cocktail, as we like to call it, or it's called, well, the first product coming from Lilly is called bamlanivimab. But anyway, those antibodies are for people. They don't help people keep from getting it. They are given to people who already have it, and those people that have it, the high risk group, we know there's a high risk of patients that are more likely to get a severe course of it. And so the antibodies have been shown, if you give them early in the course, and I'm saying like 3 to 10 days from the time they find out that they have COVID, they have been shown to decrease the risk of having a severe course of the disease. So this is for people. This is not something of whether or not you wait for you take this or you wait for the vaccine to come out. This is for people who already got the disease. And what we're trying to do is lower the impact of the disease by giving them these antibodies. Now, I mean, there's still a lot of questions unanswered about some of this stuff. For example, with the vaccine, I don't know what the current CDC recommendation even is about if you've had the disease, whether you should get the vaccine. I'm thinking that yes, you should probably get the vaccine even if you've had the disease. But yeah, some of the other things are, how long do these antibodies last, and do you need to get the vaccine right away? Some of the questions are just not answered yet.
Any other questions? Sonia? Your mic's not on, Sonia.
There we go. This is not about the vaccine, but I want to talk just a little bit about the state reports. The Department of Public Health is publishing every Friday a report that shows the variety of sites that the contact tracers are identifying. And I'm going to hold this up so you can see what I'm talking about. It's a report that looks like this. And we can send you the website if you wish. But it cites all the places, schools, restaurants, hospitals, etc. And this information is interesting and helpful to understand the widespread potential for this. But sometimes this information is not being used as clearly as it could be. And it's been used to say, well, restaurants and bars are not any worse than all these other places. So why are they being penalized, so to speak? And what's the health department doing about this? And I kind of like some response that is going to make sense as we talk back with the public about this.
So, if clarifying the question, is the question, what's
How do we deal with people? How are we answering this question about why it's important to regulate bars and restaurants? That's kind of the summit substance. And as opposed to all the there's other shops that are open. So what's kind of an official stance that we can all kind of walk away with?
So, if this may be a question for our legal counsel.
Okay. Chris is on?
Mhm.
Yeah. Well, his light's on. There he is.
I'm here. It just takes a second to get to it.
Yeah.
I'm not sure what you're asking. You referred to data and then our position.
How do we respond?
How should what?
So how should we respond when individuals?
How do we respond as a county health department when people say, how should are saying, look, this is no bigger problem than some of the others. Office settings are problems. We're not closing offices, workplaces. We haven't closed factories down. We've just closed bars and restaurants. And I realize the health department hasn't closed anybody. I know that. But Chris, is there any response that feels comfortable to you when that's being said?
Well, first, I don't hear a legal question in there. I just hear a philosophical question or a science question, but not necessarily a legal question.
Okay.
And I mean, whether or not there is a legitimate scientific basis to close bars and restaurants versus other venues is really not for me to say.
Okay.
Or for the health department to say. In my opinion, you have, or maybe it is for the health department, but it's certainly not a legal question. It's what is the status of the law right now? What are the regulations and what is the state telling us to do? And I mean, those are easy answers. You can refer them to the statutes. As far as what we're going to do as a legal strategy to do that, I've told you, and I'll continue the same. I'm not going to discuss that in a public forum in a vacuum. We're going to consider every case based on its facts, and we'll apply the law and take the appropriate action. If you want to talk specifically about what those actions might be or what our positions are with respect to the enforceability, you're all welcome to contact me. You're all welcome to come and see me, and I will talk to you in my office or by telephone about those things individually so that we maintain the attorney-client privilege. And I'm not going to discuss, and I don't think it's prudent to discuss the specific legal strategies in a public hearing.
Okay, thank you.
You're welcome.
I'm fine with that.
Hannah?
I'm sorry, I saw Andrew's hand up too, and I just was going to briefly comment on what your question was, Sonia, from my board member's perspective and kind of hitting on what Chris answered. I think our answer is that the state has issued these guidelines and mitigations, and based on the information, you know, the Department of Public Health and other people who are making their best judgment as to what can help stop the transmission of the disease, and our job is to follow those guidelines. I understand people differ on it, for sure, but I think, you know, it's a more matter of what the state in their wisdom has decided.
Andrew?
Yeah, so just to get back to the vaccine, at the risk of just sounding silly. So we have the vaccine of most dangerous pandemic that we've seen in a while. And so people are acting strange. When we say like the health department is picking up the vaccine, is someone from the office picking that up? Is that a secure? I mean, what's the accountability for when we distribute? Obviously, we put great faith and trust in all of our medical workers, but during these times, I would see that it's going to be cause people to think a little differently. Or has there been cases of anyone getting the vaccine and that's caused people to get up in a tizzy on why these people first, and all these kinds of things that can come up with holding the cure to what everyone's so fearful of right now.
Yeah, so again, things that we're definitely discussing. And for the transport, we're looking for a local law enforcement collaboration, and for the escort to get that and bring it back. And then for our vaccine sites, security will definitely be a high priority for us. So we're working out the details of that, because yes, this is something we want to always prepare for the worst and then be, you're ready.
Okay, awesome. And then the follow-up to that was, I know we talk about hospitals and medical staff first. Is there a thought to also get it to, I know you said police officers, but what about like youth therapists and youth counselors and even adult counselors? If I'm hearing that addicts aren't able to meet and they're doing it over Zoom, that's a terrible thing. I mean, that's just not going to be effective. So are we thinking about drug counselors to get those things first? Because if deaths start to rise due to depression, more drug use, more alcohol use, more things, and it's outpacing COVID, I think we got to look at who are the other essential workers that we have to get these vaccines to as well.
Yeah, we're definitely thinking, and there's multiple tiers of that, even that first couple priority levels. And so those are good that I'm not sure on our thought process, but beyond the hospitals, then after that is anyone who's working in those critical infrastructure. So they're definitely one of the first priorities of people that help keep our society running. But those are good.
Corey?
This is Dr. Nutty. One of the breakdowns I've heard is if your job in healthcare entails you work with over 50% of the time with COVID patients. So people in our prompt care, fever clinics, ICUs, they would be our highest priority people because their job entails that dealing with those people at least half the time. That's the first group we're going to target, and then secondary from other healthcare workers. So, there's not going to be enough vaccines the first wave that if you look at just doing the numbers across the country. So we got to prioritize who's going to get the first batches.
Yeah, I just wanted to make the point that these questions are all so good, and you're right. There are a lot of people that deserve to get vaccinated in a priority way, and so I know you're working on a communication plan, because clearly the community, the county, is going to have to know exactly what that sequential priority order is, so that you're not answering the same question 100,000 times, or you're not being accused of making decisions that are not judicious decisions. So I know you've got the emergency prep department, right, and probably the health promotion working on, and that's why I was talking about earlier some of the connections we've made, like with the health committee of NAACP. We want to make sure all of these different groups are clearly communicated with, so they can communicate it to their constituencies. And I know, am I correct, Jessica, that that's a big part of your big plan? Because that's being proactive, not waiting till it hits and then people start being, well, what about this group? What about that group?
Yeah, that's definitely the bones of the plan, but much more information is definitely needed before we can put any more information out there.
But do you also feel like you've got good stakeholder contacts within the county, so that word can be spread by people that will be considered trustworthy and compassionate toward their particular constituency?
Yeah, there will be other agencies besides just the health department giving the vaccine. So bringing them in to the conversations already, just so they can be prepared with the messaging and the information that we're getting as well.
Dr. Ginsburg?
Yeah, first of all, my guess is that we're not going to be seeing much vaccine in the next month or two. We're not on the 50 county list, and I have a sneaking suspicion that we're not going to really be seeing a significant amount of vaccine until the spring sometime, would be my guess. Now, that being said, having been around in the H1N1 days, I remember at that, and actually the health department took the lead on all of that vaccination, and they did something at the Interstate Center. I think for several days they were giving out vaccines at the Interstate Center. So, because I don't think you'll be able to do it out of the facility you're in right now. But I did have a question for Jessica. Sonia put up that little pie chart from the state. Are we keeping any kind of statistics from our contact tracing?
Not specific in that measure. That information goes through the Salesforce. So that's the program that we use to do contact tracing. And that's where it's actually being pulled from for those regional reports that IDPH has. So we don't have, I don't have a report that we run at this time.
Okay, I was just curious because yes, there's a lot of debate out there about the restaurants and the bars and everything, and Bloomington and Normal seem to be going in the way of they're kind of taking over their own enforcement and fines and things like that. And the people that are arguing it on social media keep saying, well, why didn't the health department come in here? Why didn't the health department do this? And I think that was the question that Sonia was trying to get at, is what is the role of the health department in all of this? And I don't know that it's ever really been totally clear. I remember way back months and months ago when Don Knapp gave a whole talk about, enforcement, and but it's kind of like the state sets the mitigation things, but leaves it up to the local governments to enforce. And I think that there's some local governments are not as willing or not as able to enforce them as others. And so that's why it's kind of hodgepodge all around the state.
Is there a plentiful supply of the antibiotic cocktail, or is that limited to, by region or whatever?
Well, there is a clinical supply in that both OSF and Carl have supplies of the cocktail. I found out today that I believe we had 50 doses of the single monoclonal antibody. But then on top of that, they had the cocktail to be used after they run out of that. So there definitely are doses available, and they're in town.
Judy?
Yeah, with regard to what the health department should be doing, Jessica, I'm reminded that I think Tom Anderson, I don't know if he's on the call this evening, he's gone over with us when he receives a complaint. We do have steps in place as to how we respond. Is that correct? And it may be helpful if we kind of get that in some kind of a brief fashion, because we do have a response, that's my understanding. And then at a certain point, it has to go to the state attorney. Or if the municipal government decides to do something with it, as Bloomington has recently done, then I think we just need to acquaint ourselves with that, because the last thing we want to do is be perceived as not doing anything, because I think it's quite the opposite. And I see Tom is here with us. So maybe, Tom, when someone calls you with a complaint, why is this restaurant doing this or that? You do have a rather set of steps, correct?
We do, and that was mainly for complaints on social distancing and the lack of wearing facial masks. It's a little bit different in that the state wants us to basically go through a three-part step of notifying. Step one being notifying the business that there's a complaint against them. If there's a second complaint, they want us to personally witness that violation when it occurs, and if it is occurring, they want us to present in order to disperse, to cease, to desist. Concern with that is that it's not safe to send people who are trained in crowd control to go to our populated restaurants and so the steps that we're taking is by contacting them formally by letter. Mr. Spanos is receiving and Ms. McKnight are receiving carbon copies of all the letters that we send to the businesses, notifying them of the complaints that we're getting. Mr. Spanos has informed me and Ms. McKnight has informed me that they are watching the number of complaints that we get on in an establishment, and Mr. Spanos has been sending out letters directly from the state's attorney's office notifying some of those businesses that they are in violation. Mr. Spanos and I have been playing phone tag this week. He wanted some more procedures to me, but I haven't had anybody to connect with him. As far as going in now and trying to disperse the crowd, my staff aren't trained for that. There's a number of videos posted on social media showing health department personnel being intimidated. Most recently, there was quite an intimidating situation in Buffalo, New York. Most recently, our food program supervisor's counterpart in Champaign County was in an intimidating situation. That both situations required the assistance of the police. I don't want to put my staff into that position. So we are notifying them by letter and keeping track of the violations that we're receiving, the notice of violations that we're receiving. To help with the situation, to help Mr. Spanos and anyone else from the state's attorney's office that are keeping track of these, we are documenting the number of notices that we're sending to the particular establishments. City of Bloomington has followed up on that. We all know, we've seen it in the media, that there's a number of establishments that have been pulled, asked to attend their liquor commissions and explain themselves as to why they're not cooperating. Did that answer your question?
Yes, in fact, I have a specific, I'm going to send Chris a question. I have a question about maybe an option that we may need to talk about, but I think I'll just direct it to him in a question via email. Thank you, Tom.
Andrew?
Just maybe not so much a question, but just trying to wrap my head around this. So someone makes a complaint to the restaurants, and have we thought about? I guess I was thinking from Black communities and other minority communities that have felt like a lot of Black youth that we speak to. A lot of the violence and things come from whether it's perceived desperation or actual desperation. So as we're going in and making whatever the referrals are we taking note of if these are people's livelihoods and businesses keep closing, the desperation again starts to rise, and then drug abuse and alcohol abuse begins to rise, and ultimately violence. When you start pitting people against taking care of their families or staying open, I think you're putting business owners in predicaments that nobody wants to be in. That is tough, for a family to say, you're shutting me down, but this is how I feed my kids and my family, and I'm not trained or able to do anything else. I mean, we're taking these calls, are we taking these seriously, or is this, hey, someone is just calling? All these things consider it as what happens if we keep moving in that direction.
Yeah, so we have a due diligence to follow up on all the complaints we receive, but the first step is always, reaching out to the business owner to talk with them and educate, because we want to get voluntary compliance. And often that we receive voluntary compliance by reaching out to them, and the one step is all we need.
Hannah?
And I'm sorry, I just want to make sure I understand the vaccine, where we're going from here, because I guess I'm concerned. I know that there's no national anything, and it's set to the states, and then of course down to the local level. And it's clear, I think, that at the first level, the healthcare workers, frontline workers, are no question about that. But I think Andrew made a good point about, as it gets past that point, then there's a sense of like, who gets it and why you and not me, et cetera. I mean, except for the apparently 50% of the people who won't take it at all. But so we are the first line for the healthcare workers. The health department picks it up. At what point do other people have the opportunity to go and actually get it from the distribution center? Is it always us? I'm sorry if I missed that, but at some point then it opens up, and then we are just another client, as it were, at that point, right?
And I don't know what the exact point is. So the first couple shipments that we're getting the Pfizer vaccine has to be kept ultra cold, -80. So the state has actually purchased ultra cold freezers, and that's one of the reasons why it's being distributed this way, is because not all the counties have an ultra cold freezer or will have one. So that's why the first couple shipments for sure will be distributed this way. In the future, those shipments may come directly to the health department. We wouldn't have to necessarily go pick it up. So it won't always be that method.
But are we always the first point of contact, so that we always get it and then we distribute it in the county?
At the beginning, I don't know at what point we won't be. And I don't know if there will be a point that we won't be. It hasn't been finalized yet of at what point is it not the health department being the distributor.
Okay. So my next question then is, and I know there's tremendous amount of things on your plate, but I just feel that this is very important. And I know you've said you've been talking and there's lots of planning going on, and appreciate what Dr. Ginsburg said about maybe spring, but time can fly. And I really think we need to really be clear that we have a very clear plan, because I think there is very good chance that the public, as this rolls out, past the very obvious people who should get it, to the next layers of that. And so do we have any kind of a task force or group that is formally put together that is now putting these recommendations out there? And is it something that would be the county board might approve, or we might approve, in terms of how we do that?
We have a plan that we had to create to send to the Illinois Department of Public Health to supplement into their statewide plan. So there is a plan, but it continues to change as the information changes as well. But yes, there's definitely a plan.
Susan?
I think that I read, might have been on the CDC's website, on the different groupings of priorities, and that in each grouping there's like priority 1, and there's like A, B, C, D, E, F, where you kind of just go down that list of, in priority 1, you have healthcare workers. Okay, so that's a lot of people. So then they go through, and I believe that's prioritized down through that list, like with maybe the COVID, ICU, ER, people might be first, kind of thing. And I thought that was on the CDC website. Was I correct on that, Jessica? Where CDC is kind of dictating quite a bit of this prioritizing level, or is the state website? I can't remember which one I saw it on.
They're both really setting the tone, obviously, for the prioritization. And like you mentioned, phase one has multiple layers to it. And, again, the last information that we have, we will move through phases as a state, but you may move through the A, B, C, D, E of phase one on your own as a county, depending on, vaccine availability and your population size. So, we will probably be in phase one for a long time because there are a lot of different groups in that first phase and a lot of different sections in that first phase.
Corey?
So I'm going to switch gears just a little bit, but another question that we might, just one more thing you need to think about, Jessica. So I attended a webinar that was put on by the Society for Human Resource Management. So that's an international association for basically HR. And one of the things they posed was businesses are going to have to decide if, particularly certain types of businesses, whether they're going to allow vaccination of their employees, if they're going to make it mandatory for employees because of the nature of the work that the employees might be doing. So as a health department, I wonder if we've had that thought and if we have to think about that, and maybe there's legal implications of that. Like, would we expect our workers that we know are out in public on a regular basis, would we certainly want them to get the vaccination? But what if we had someone who said, and I know there are certain reasons why you can opt out, but would we in general have to do any kind of a policy related to our expectation for our workers taking the vaccine? And do we also need to give guidance to businesses on how to handle that?
So our current policy does not require, so, the same thing with the flu shots, we don't require employees to get those vaccines.
Any other discussion?
I just wondered, is that something the hospitals have thought about? The two doctors, like if any of their essential healthcare workers decide they don't want to be vaccinated?
Well, right now, I have not heard anything saying the vaccines are mandatory. And it's just something we're going to have to work through. I mean, our flu vaccines are mandatory, but it's something that's going to work itself through, I guess.
Yeah, we have a similar approach right now. I think the newness of the vaccine. I don't know if we're going to require it. We're going to offer it. We do require the flu vaccine. That's a required immunization. There's more history at that, of course. So.
Any other questions? Thank you, Jessica. We've got a couple different action items tonight. Approval of resolution establishing fees for service. I think you'll have the fee list in your packet. Were these same as last year?
Mm-hmm. Yes.
So they haven't been bumped at all?
Nope.
Okay. Is there any motion to approve these? Judy, motion? You second? Corey, seconds? Any discussion? Anna?
I just have a question. Last time I thought there was a question about whether we could have a reduced payment for the flu shot, I think. And the fee discussion came up in that context. So you just said, Scott, that the fees are the same as last year. So did we address that? Or am I just not remembering that question correctly?
It was a question, and I think as it was, the fees were already set, so it couldn't be really changed. I think I should have brought up in the summer rather than late fall, so I think it's maybe a little late now to consider that. It's up to the board, I guess. So.
Is the flu vaccine fee on the schedule? I couldn't see it, but I don't read that as well.
I believe on the website it was $30 if you don't have insurance. But I think it varies in the fee schedule here.
Would there be a reason tonight to consider amending this to reflect a range or something that would allow for a lower cost? I mean, if we're approving it for next year's fee.
Mm-hmm.
So there are policies that, if you, so there are policies about fees that, if you bill Medicaid, then you also have to charge the same fee for anyone, whether that be insurance or non-insurance. So that's where, we set these fees based on that.
Yeah, I think if you start giving it free to people without insurance, then you're gonna have a lot of trouble billing other insurance companies that say you should give it free to our clients also.
Yeah, I wasn't even thinking free. I just know that somebody had raised the issue because they were in to make sure people got the vaccine. So that's fine.
Okay, so well, vote, yes.
Call the question.
Allen Ginsberg,
Aye.
Andrew Held,
Aye.
Corey Tello,
Aye.
Hannah Eisner,
Aye.
Judy Buchanan,
Aye.
Richard Janetti,
Aye.
Robert Kulhase,
Aye.
Scott Hume,
Aye.
Sonia Reese,
Aye.
Susan Schaefer.
Yes.
We have some contracts to approve for the dental staff and the medical advisor. We group these together, did you say? I think these can be all grouped as one vote. Would anyone like to make a motion to approve these contracts? Rob Colhase, and second by Sonia. Any discussion? On the question?
Allen Ginsberg,
Aye.
Andrew Held,
Aye.
Corey Tello,
Aye.
Hannah Eisner,
Aye.
Judy Buchanan,
Aye.
Richard Janetti,
Aye.
Robert Kulhase,
Aye.
Scott Hume,
Aye.
Sonia Reese, Susan Schaefer,
Aye.
We have a list of meeting dates for next year. Would anyone like to make a motion to approve these dates? Susan? And second? Corey? Any discussion? Call the question?
Allen Ginsberg,
Aye.
Andrew Held,
Aye.
Corey Tello,
Aye.
Hannah Eisner,
Aye.
Judy Buchanan,
Aye.
Richard Janetti,
Aye.
Robert Kulhase,
Aye.
Scott Hume,
Aye.
Sonia Reese,
Aye.
Susan Schaefer.
Yes.
Action item D, we have a approval of $50,000 for Project Oz and the Clayton County Center for Human Services. I believe this is in a committee. Do we have a motion to approve these $50,000?
I so move.
Judy and
I'll
Alan.
second.
Is there any discussion? Andrew? Call to question?
Allen Ginsberg,
Yes.
Andrew Held,
Aye.
Corey Tello,
Aye.
Hannah Eisner,
Aye.
Judy Buchanan,
Aye.
Richard Janetti,
Aye.
Robert Kulhase,
Aye.
Scott Hume,
Aye.
Sonia Reese,
Aye.
Susan Schaefer.
And action item E, approval of wellness statement of work for wellness. A motion to approve?
I'll move.
So moved by Sonia, second.
Second.
Hannah? Any discussion? Susan?
So this was, we talked about this last month, correct? And there was some issues with
Confidentiality?
confidentiality. Was that all, has that been addressed to everyone's satisfaction?
Hannah?
Yeah, I think I had raised that question in the past, and the document we got in our packet is different from the one we first received, and it just provides for providing email address, employee email addresses and no further information. So I was satisfied that it addressed my concern.
Any other discussion? Call the question.
Okay. Alan Ginsberg,
Aye.
Andrew Held,
Aye.
Corey Tello,
Aye.
Hannah Eisner,
Aye.
Judy Buchanan,
Aye.
Richard Janetti,
Aye.
Robert Kulhase,
Aye.
Scott Hume,
Aye.
Sonia Reese,
Aye.
Susan Schaefer.
Yeah.
I think that finishes everything tonight. You have a motion for adjournment? Susan, second by Sonia.
Actually, I want to say something. I want to add a compliment to the team that's leading the contact tracers. I have a friend that's doing that, and I've talked with her a number of times, and she is so pleased with the support that she's getting from Kyle and Juan. She said it's really very, very helpful, and she's grateful for their patients that come and talk with them. How are you doing? And it makes a lot of difference. So, Tammy, I don't know if you're the team leader on that, but if you are, just know that what they're doing is appreciated.
They are an awesome team. And your friend is killing it. She's doing a good job.
That's great. I'm so glad. Well, she is loving being there. Now, you know, being on the phone all day and talking to people who don't want to talk to you necessarily isn't always the most fun. But she understands that that's part of the job and it's what she needs to do. And so I'm grateful for that. So I just wanted to pass everybody, pass this on to everybody to say, this is not an easy job, but having good leaders and people like Tammy giving them guidance is also a good thing. So thank you to everybody on behalf of my friend and all the others that are doing this for us. We appreciate it. Okay.
Thank you, everybody. Have a safe holiday season. We'll see you next year.
You will.
Thank you.